an imaging radiologist with a special interest in prostate cancer, imaging diagnosis, image-guided biopsy, and image-guided treatment. And I'm very happy to be here to speak on this exciting technology in our experience with it. I thank Profound for the opportunity to speak. As we know in prostate cancer, there are many problems with the existing paradigm for diagnosis. Although PSA was a big advance when it was introduced in the early 90s, it has many, many problems in terms of diagnosis. It basically overdiagnoses indolent disease and underdiagnoses sort of more aggressive or relevant disease. And as you can see, even at a cutoff of 4, which is the common indication to trigger some further action, only about 20% of men will have any cancer. And it creates a lot of anxiety in the other 75% of men who don't have cancer. So there's a lot to be said here. So even though it's good for sort of understanding some cancer, it's not a great test by itself. It doesn't tell us where, why, or how anybody has cancer. Then this is followed up with a TRUS biopsy, or transrectal ultrasound biopsy, which, while okay, the performance is again lacking. It's the only solid cancer that's not really imaged, nor is there an image-guided biopsy of a precise cancer. That's the only cancer, and it's as large as breast cancer in terms of a problem in Western society. And we think prostate cancer care is blind. So Dr. Patrick Walsh from Johns Hopkins, who pioneered robotic prostatectomy, basically said as much in 2008 when he said, the discovery that would have the greatest impact on our field would be the development of accurate imaging of the tumor within the prostate. And we have certainly taken that to heart, and we believe MR imaging is the best thing to happen to prostate cancer care since radical prostatectomy and the PSA. We think with MR, we can look at the T2, we can look at the diffusion, we can look at perfusion or contrast enhancement, we can look at spectroscopy in certain cases if we need to, which provides some imaging of the constituents of the prostate. And then we now have MR PET and PSMA to understand prostate even better. And all of these things enable us to grade and stage prostate cancer in a way that's never been possible before. It's very exciting. And now we can then biopsy these abnormalities very nicely. We also have a way in PIRADS to talk about the prostate and level the playing field between urologists, radiologists, pathologists, and others. So these are all exciting developments in prostate cancer over the past 5 to 8 years. And then most exciting of all is the therapy that we can now undertake with these precise imaging markers and apply that to an imaging-based therapeutic, minimally invasive format. And I think that's the best thing that's happened, and I'm very excited to talk about it. We are very committed to understanding MR imaging and prostate cancer. Here in the largest series, looking at precisely matching MR to radical prostatectomy, we basically took our MR images, all 4 of them, T2 and the others, and then slice the prostate in a very specific orientation to match the MR and show exactly where the significant cancer is here on the left side, as is shown on the MR, and what's not shown on the MR is the insignificant cancer that's missed here on the right side. So this is what we want to do, and we show basically that we could predict and find about 80% of the time larger tumors, the most aggressive Gleason tumors, the index tumors, and unifocal tumors, all around 80% of the time. And then further, we can find the tumors and talk about it. We can grade them here. This anterior cancer was a PIRADS 5. And then we can then take a biopsy device and precisely biopsy the lesion and find, as we expect, Gleason 3+4 disease in 5 of 5 cores. And this was never possible before. So we've shown in these biopsies that if we take PIRADS 5, we can predictably achieve 80% prostate cancer detection, which is much, much higher than TRUS biopsy. And 70% of those are clinically significant. And we've shown that in 2 large series showing that at a PIRADS 5 level, the majority of cancers we detect are clinically significant, and we detect cancers in almost 80% of cases. So this is a very exciting paradigm. I think with TULSA-PRO, this just is the icing on the cake for a man with prostate cancer. We can precisely image and biopsy the cancer. We can then ablate the cancer in an outpatient setting without a lot of other problems, and then as an outpatient monitor for recurrence and other problems. So here, when the treatment's performed at the end of it, we know exactly what we've treated. The whole gland is dark because all of the perfused tissue is now dead. It protects the urethra, it protects the rectum, protects the nerves out here that lead to impotence and incontinence, and it protects other things. So we're very, very nicely looking at these parameters with MR. So precise treatment, real-time monitoring, closed-loop temperature control, and post-treatment contrast enhancement to understand the disease and the treatment, then monitoring on follow-up for the area, for volume reduction, and for recurrent disease. And here in this video, on the treatment day, we align the transducer here in the urethra, and here you can see it on the sagittal. We then draw out our boundaries very precisely to avoid the nerves, to avoid the rectal wall, to avoid the bladder neck, and to avoid the urethral sphincter. And all of those areas are danger areas. And I believe no other competitive technology offers this level of precision in how a prostate is outlined. So this is very exciting, and this is what I would want for myself or my loved one in a treatment of this type. And then when we treat, the best thing is we can see the treatment in real time, and no other device has this, where we have real-time temperature monitoring of what's exactly being ablated. So if we get out here in the yellow, this is lethal temperature to exactly where we want to be, out here at the edges. And we can always go back and fill in these little gaps that aren't yellow. And we can treat as much or as little as we want. We can treat the entire prostate, or we can treat only part of the prostate, and provide an individualized treatment plan for each man. So this is very exciting and unavailable in no other technology that I know of. And we have a predictable prostate volume reduction on MRI here. The ablation is visualized immediately after treatment with contrast-enhanced MR. And the non-perfused volume centrally here, all this dark area is dead tissue, and the peripheral enhancement is the live vessels and nerves out here in the periphery. The ablation can be monitored after treatment with predictable volume reduction. So here the prostate is kind of crinkling up as it gets smaller, and the PSA is dropping quite dramatically, as you see here. And almost unrecognizable, there was a prostate gland even present here at 12 months. Prostate volume reduction is significant and predictable. And we also have predictable disease control on MRI. In our series, only 11%, 1 of 9, had a positive biopsy, and we know exactly why that happened. The positive biopsy at 12 months, we know that on the treatment day, we underheated the target area here. We underheated the target area. We had disease on left and right, but for some reason, we couldn't get enough temperature dose here to kill that tissue. And we could see that on the contrast-enhanced area here, that was undertreated. And of course, 12 months, the MR was positive in this area with T2 showing dark and diffusion restriction, and that area when biopsied had Gleason 3+4 cancer, and the patient is now undergoing a salvage radiation treatment of that area. So even when it fails, we know most of the time why it fails. We undertreated the area for some reason. In our experience, we had 100% NPV, and that was mirrored in the overall experience, which was 92%. And we knew that we had dramatic decreases in prostate volume, almost all men, in the 90s, 80s, and 90%. Even in the one that failed, had 66% reduction in volume. But unfortunately, only 1 of 9 had this treatment failure. But again, predictable why that was. So in conclusion, I think MR imaging has revolutionized the diagnosis of prostate cancer. We know exactly where the cancers are. We know exactly where the high-grade cancers are. We know where to go and how to biopsy it. So we can precisely detect high-grade cancer. And I think TULSA-PRO extends this and revolutionizes the treatment with this minimally invasive outpatient procedure, cancer and possibly BPH. And it's the only technology that enables real-time guidance with what I think is critical, temperature monitoring, to understand where to heat and where not to heat. And that's very important, and nothing else really does that. So I thank you for your attention.